and I have the honor of introducing our next two speakers. Dr. Elka Jacobson-Dickman is an associate professor of clinical pediatrics and the associate dean for clinical medicine at SUNY Downstate, where she oversees the core clinical and advanced clinical medicine years of the integrated pathways curriculum. She works with the clerkship and other rotation directors to assure the highest educational quality and supportive learning environment for students. Dr. Jacobson-Dickman obtained her Bachelor's of Science degree from McGill University in Montreal, Canada, and her medical degree from Albert Einstein College of Medicine in the Bronx. After completing a pediatrics residency at Albert Einstein College of Medicine, Children's Hospital at Montefiore, and a pediatric endocrinology fellowship at Harvard Medical School, Mass General Hospital, she joined SUNY Downstate and Maimonides Medical Centers, where she ultimately became the Pediatric Endocrinology Fellowship Program Director. At Maimonides, she also served as the hospital-wide Director of Faculty Development. While she cares for the children with a wide range of endocrine disorders, Dr. Jacobson-Dickman has a long-standing interest in puberty and reproductive endocrinology. She also published research in these fields and is the co-director of the College of Medicine's first-year reproductive endocrinology course. Dr. Jacobson-Dickman is dedicated to practicing compassionate, patient, and family-centered clinical care and in implementing medical school curriculum where professional reflective practices are emphasized. I can truly say it's an honor to work with Dr. Jacobson-Dickman, Elka. We also have one of our close affiliates, faculty who is joining us as well. Dr. Nuri Jacoby is the Chief of Service and Vice Chair of Neurology at Maimonides Medical Center and an Associate Professor of Clinical Neurology at SUNY Downstate. He graduated from medical school at SUNY Downstate, after which he completed a neurology residency and an electrophysiology EMG fellowship at Weill Cornell. He is the co-director of the neurology clerkship at SUNY Downstate, as well as an associate program director at SUNY Downstate's neurology residency. He is passionate about medical education and faculty development. He's given multiple presentations on giving effective feedback and bedside teaching, and has developed several faculty development modules on feedback and medical student assessment. He is active in medical education research and was awarded the Faculty Innovation and Education Grant from the American Board of Psychiatry and Neurology in 2020 to develop a neurology e-learning didactic curriculum for psychiatry residents. We thank them both for bringing us their lecture, The Power of Language, What Our Words Communicate.
Thank you so much for that wonderful introduction, Teresa. And it's been my honor as well. So today I'm so pleased to be speaking with you. I've partnered with Dr. Jacoby in creating this session that we call The Power of Language, What Our Words Communicate. For the purpose of today's session, Dr. Jacoby and I have made an explicit choice to refer to one another by our first names. In lieu of a roadmap for the day for our session, our plan is to discuss the power of words and the bidirectional impact of language and values, the impact of stigmatizing language on patient engagement, management, outcomes, and racial justice, how stigmatizing language impacts and perpetuates implicit bias. We will describe how words have power to influence inclusivity in the clinical learning environment and how they influence the tacit dimensions of the medical education process, also known as the hidden curriculum. And finally, we will take a case-based approach to demonstrate strategies for reducing stigma and bias in our communication, including self-reflection, language audits, and incorporation of precise and objective patient narratives. George Orwell said in an essay from 1946, "Slovenliness of our language makes it easier for us to have foolish thoughts." Paraphrased loosely, laziness in word choice leads to laziness or poor thinking and decision-making. Our words not only reveal our values, but they also inform them. George Lakoff, a well-known cognitive linguist, said, "Language is not a neutral system of communication. because it is always based on frames, conceptual metaphors, narratives, and emotions. As physicians and as healthcare givers, we must be conscious and cautious of the judgments inherent in our words. It is not hyperbole to say that our words affect and shape global policies and allocation of resources, and on the ground that our language affects our therapeutic relationships with our patients, clinical outcomes, and role modeling of professionalism. Health equity work and progress requires an acknowledgement and reconsideration of previously taken for granted beliefs about health, healthcare, public health systems, and society itself. Central to the advancements in health equity is the consideration of our language and the narratives that shape our thinking. Dominant narratives, which are also referred to as malignant narratives, are stories told in the service of the advantaged social group's interest. They limit our understanding of the root cause of health inequities and undermine public health and health equity advancement. Our words and language become messages that inform stories and narrative, which become deeply ingrained and interconnected. Importantly, opportunity exists at each level of this narrative ecosystem to either perpetuate the status quo or to challenge and dismantle existing injustice. Figurative language is ingrained in our communication. It guides how we view the world, our patient relationship, and our role as physicians. Words matter. In a sense, language is an exercise in values decoding. Consider the following examples, if you would. The term vegetable is used often synonymously with the clinical term persistent vegetative state. When confronting scarcity, for example, one can imagine how this metaphor might influence decisions and policies. An attending might invite a learner to join them to see the heart failure down the hall. A synecdoche is a form of figurative language which defines an object by a part, reducing a patient to an underlying organ, or a pathology in this case. On morning rounds, describing a code from the night before, perhaps you've heard a well-meaning doctor say, "The patient tried to die on me," implying an adversarial stance on the individual's will or desire to live. A patient failed chemo, or is it too psychologically unbearable to accept that we were powerless to help? In a pediatric history, we often hear "as per mother." Medical histories inherently are patient and patient families' narratives. Why must we separate ourselves and perhaps even imply skepticism? And lastly, report and denied. These words are sprinkled generously in medical histories. Why should we be conjuring the image of an interrogation? But I'd like to take a step back, if I could, for a moment and define some terms. Firstly, what is stigma? One definition is an attribute, behavior, or reputation that is socially discrediting. So how can we tell if the language we're using is stigmatizing? Does it cast doubt on a patient's experience? Perhaps it portrays the patient negatively by implying culpability, using pejorative linguistic variations, implying a stereotype, or using unnecessary details that might bias future providers or learners. What is implicit bias? Well, it can be defined many ways, but perhaps I'd offer this. The automatic activation of stereotypes, which may override deliberate thought and influence one's judgment in often unintentional and unrecognized ways. And what are some outcomes of implicit bias? Well, disrupting therapeutic alliances with patients, discriminatory treatment decisions, prejudicing colleagues and learners, and certainly poor role modeling.
Hi, everyone. I'm Nuri Jacoby, and I go by he, him, and his. I'd like to thank Elka for inviting me to partner with this talk. It's an honor to have the opportunity to speak about such an important issue. Before I discuss the first case, I think it's important to emphasize that we're only going to discuss a few cases in this presentation, but there are many historically marginalized groups and stigmatized conditions that we aren't discussing, but very much apply to this talk. Okay, so on to the first case. Let's look at the beginning of a sample history of a patient and see what we think about the word choice. A 72-year-old diabetic Black man presents to the office for follow-up. He's on metformin, though is non-compliant, and his hemoglobin A1C is 14.5. Think about any words here that may be stigmatizing. Many of us recognize that implicit bias is a problem in the United States, though some may question whether it's a problem among healthcare professionals. This has been studied. A 2017 systematic review that looked at 42 articles from 2003 to 2013 measured implicit bias among physicians and nurses with the Harvard Implicit Association test, among other methods. It found that healthcare professionals exhibit the same levels of implicit bias as the wider population. While implicit bias has been looked at on a number of different groups and conditions, it's been studied most in regards to race. And the conclusions are the same, with low to moderate implicit bias noted. So we know that implicit racial bias exists among healthcare professionals. Now let's look and see if there are differences in the language used in the EHR between white and Black patients. A study published this month used machine learning to analyze health records from an urban academic medical center to answer this question. They found that Black patients had 2.54 times the adjusted odds of having at least one negative descriptor in the H&P. The most common negative descriptor was refuse. The second and third were non-adherent and non-compliant, and the fourth most common was agitated. And here you can see some of the other negative descriptors that were seen. A similar study published this year found the same conclusions, with more stigmatizing language found in the notes of Black patients. Hopefully, we have demonstrated that there is both higher racial implicit bias among healthcare professionals and that there's more stigmatizing language in the notes of Black patients. It isn't hard to see the connection between the two. So the next question is whether implicit racial bias and stigmatizing language used with patients affects treatment decisions and patient outcomes. In this study by Anna Gadu and colleagues, the researchers employed an experimental vignette study design in which residents and medical students were randomized to read one of two chart notes presenting medically identical information about a hypothetical patient with sickle cell disease. The first note utilized stigmatizing language and details, while the second used neutral language. After reading the chart note, participants completed a survey assessing their attitudes regarding the patient and treatment decisions for the patient. They focus on a patient with sickle cell disease, as there is significant evidence that these patients are stigmatized by clinicians and experience inadequate pain management, conflicts with staff, and lack of respect. They decided to focus on medical students and residents, as training is a time of socialization through the hidden curriculum, and thus a potential point of intervention. So how can you tell if this language is stigmatizing? We can use the rubric that Elka talked about. So in the stigmatizing language note, it said, who comes to the ED stating he has 10 out of 10 pain, while the neutral language note said, who comes to the ED with 10 out of 10 pain. By writing that the patient stated 10 out of 10 pain, we are casting doubt on the patient's experience. The results of this study demonstrated that the stigmatizing language was associated with more negative attitudes towards the patient and less aggressive management of patient's pain, i.e., discriminatory therapeutic practices. Importantly, this study demonstrated scientifically the role that language plays in role modeling professionalism, perpetuating the hidden curriculum and inculcating deeply rooted narratives and implicit bias in future physicians. Whether in the EHR, on rounds, or at the bedside, faculty are role models, being observed and internalized. We must be cognizant of the stage we have to influence and impact learners. So let's now go back to the case and think about our rubric and see if we can destigmatize a language. First, the language isn't patient-centered. We shouldn't define this patient by his diabetes. Second, do we need to include his race? Does that affect his management here? So I would change the first sentence to 72-year-old man with diabetes presents to the office for follow-up. Okay, so now to the second sentence. Non-compliant is a common word that's used in medical charts that is problematic if we think about it. By calling someone non-compliant, we are placing the blame solely on the patient, when really the patient may not be taking a medication for a number of reasons. There may be structural barriers that limit availability and accessibility of medications, such as cost or insurance. There may be frustration and mistrust of the healthcare system, or there may have been ineffective communication about the patient's disease. In addition, by saying a patient is non-compliant, we are labeling them, and we're running the risk of triggering biases in others who read the note. So let's change the sentence to simply describe what happened objectively. He's on metformin, though stopped taking his medications, and his hemoglobin A1C is 14.5. It's a small change, though it can make a really significant difference.
So I'm going to go on to case 2. Mr. Smith is a substance abuser. He is attending a court-ordered treatment program. As part of the program, Mr. Smith is required to remain drug-free. He has been compliant with program requirements until 1 month ago when he had a dirty drug screen and blew a number on the breathalyzer. He now awaits his appointment with the judge to determine his status. Mr. Smith's father was an addict as well. So I invite you to start thinking about, I've already labeled this stigmatizing, so you know where I stand, but start to think about what you think about this particular case, if it seems something familiar and realistic, and what is bothersome to you. And I'll go on to offer a few statistics related to substance use disorder. Firstly, more Americans now die every year from drug overdoses than motor vehicle crashes. In fact, it's predicted that in the United States, 130 people each day will die of opioid overdose. And actually, these numbers are probably underestimations because it's known that in COVID, this problem has worsened. 89% of individuals estimated to be in need of treatment for substance use disorder do not receive treatment services. Why? Well, certainly stigma is a major contributor. There are two main factors that affect the burden of stigma placed on a particular disease or disorder. First, perceived fault in acquiring the condition, and perceived control that a person has over the condition. Consider the disease of cancer, for example. There is low perceived fault and control, and then so arguably less stigma. By contrast, many people mistakenly believe that mental health conditions, including substance misuse disorders, are both within the person's control and at least partially their fault. For these reasons, they frequently attach more stigma to them. The potential for stigma is even greater with the additional perception of criminality. Now, is substance use disorder and stigma related to prognosis? Well, it is an evidence-based statement to say that people with substance use disorders are viewed more negatively than people with physical or psychiatric disabilities. In fact, even highly trained substance use disorder and mental health clinicians were significantly more likely to assign blame and believe that an individual should be subjected to more punitive, even jail time, rather than therapeutic measures. This happened when a subject of a case vignette was referred to as a substance abuser rather than a person with substance use disorder. The current DSM-5 has replaced older categories of substance abuse and dependence with a single classification of substance use disorders. This describes the constellation of impairments caused by repeated misuse of a substance. The term drug habit inaccurately implies that a person is choosing to use substance and can stop. First-person language is the accepted standard for discussing people with disabilities or any chronic medical conditions, including substance use disorder. As I mentioned, research shows that the use of the term abuse and abuser negatively affects perceptions and judgments about people with substance use disorders. Descriptors such as addict and alcoholic can have similar effects. As a result, we refer to people with these conditions as person with substance use disorder or person with alcohol use disorder. Clinically accurate, non-stigmatizing language is imperative. Various colloquialisms, particularly from law enforcement, are used to label substance use status, including the terms clean and dirty, instead of saying positive or negative toxicology screens. Precise descriptors are preferable. A person not currently using a substance, or conversely, a person using substances, or a person in recovery. A person in recovery has a range of definitions, but generally refers to an individual who is stopping or at least reducing substances to a safer level, reflecting a process of change. Okay, dokie. So back to our case. So we're going to take away all the discussion about that's pejorative and unnecessary and really having nothing to do with the patient's actual disease of substance use disorder. The background of being court ordered, this is unnecessary. So what can we say here? How about Mr. Smith is a man with substance use disorder who presented today to his treatment program. He is in recovery. He had a positive toxicology screen 1 month ago. Mr. Smith's father had substance use disorder as well.
So let's discuss the next case. A 28-year-old homosexual man presents to the office with concern for HIV after having unsafe sex with multiple partners in the last month. What do we think of this sentence? We'll come back to it in a bit. While the pace of change in public views on equal rights for LGBTQIA+ individuals has been quick and really wonderful, we still have a long way to go. 81% of heterosexual first-year medical students expressed some implicit bias towards gay and lesbian individuals in a 2015 study, and nearly half expressed some explicit bias. Interestingly, the authors discuss how explicit attitudes are susceptible to social desirability bias and have therefore changed more in recent years relative to implicit bias. And LGBTQIA+ individuals experience significant stigma, even with a change in public views. While this affects all LGBTQ individuals, I'm going to focus on LGBTQ healthcare providers to show how this not only affects our patients, but our learners and colleagues as well. A 2014 study that surveyed general surgery residents found that over a third of LGBTQ residents had not revealed sexual orientation when applying for residency due to concern of being rejected. And 59% didn't feel comfortable discussing their partner with attendings. While the numbers may have changed a bit during the last 8 years, I'm sure these concerns remain among LGBTQ individuals. And this data really connected with me. In residency, I didn't feel comfortable discussing my partner with a number of my attendings. And some of that was due to internal stigma, though some of that was because of clear biases. One of my attendings who didn't know my sexual orientation casually used the word fag with me when discussing someone else. I was obviously surprised, and as you would expect, this made working with them uncomfortable. This stigma that many LGBTQ doctors and medical students experience has real professional implications. LGBTQIA plus medical students have an 8-fold predicted probability of burnout compared with heterosexual students. So how can we help reduce some of this stigma? Well, as we've emphasized again and again, language has the power to both disempower and empower underrepresented groups. So here are some tips. LGBT is outdated and not inclusive. Use LGBTQ or LGBTQIA+, the most inclusive reference, which stands for lesbian, gay, bisexual, transgender, queer, intersex, asexual, and other sexual and gender minorities. Avoid the term sexual preference and say sexual orientation instead. Whom an individual is attracted to is not a preference, it's biologic. Use gender neutral language like partner or significant other instead of boyfriend, husband, or wife. And importantly, don't make assumptions. Not all men who have sex with men identify as gay or bisexual. Behavior does not always equal identity, and making the wrong assumption can be upsetting for LGBTQ patients and colleagues. So let's go back to the case and use our rubric to dissect the word choices. So the first issue is using the word homosexual. Homosexual often implies a medical diagnosis, and it has been associated with negative stereotypes and should be avoided, with gay man the preferred term in this example. A second, less obvious issue is the word unsafe. The terms unsafe and risky when talking about sex are used ubiquitously by all of us, as well as in the literature. But should they be? A commentary by Julia Marcus and Jonathan Snowden in the journal Sexually Transmitted Diseases argue why these words are problematic. First, using risk-based language perpetuates a long history of fear-based messaging related to sexual health that contribute to stigma surrounding HIV and STIs. Second, they attribute risk solely to an individual's decisions and actions without acknowledging the person's environment. People who have been economically or socially marginalized may have a significantly higher HIV prevalence in their sexual partner pool, or may have economic barriers to what we call safe sex. Third, these words are imprecise. What do we mean when we say unsafe sex? Does it mean not using a condom? Or does it mean having multiple partners? Or is it being HIV uninfected and having sex with a person with HIV with an unsuppressed viral load? Is sex unsafe because of the risk of HIV, or the risk of other STIs, or because of the risk of pregnancy? We should always try and be as specific as possible. So let's reword this. A 28-year-old gay man presents to the office with concern for HIV after having condomless receptive anal sex with 4 partners in the last month with unknown HIV serostatus. We aren't labeling or judging the patient. We're simply describing what happened. And here you can see some other examples of phrases you can use, such as condomless receptive anal sex with or without PrEP.
So here we're at another case. Michelle is a 25-year-old transsexual woman who presented to obstetrics and gynecology for routine health care. Her gender preference is male, and she asked to be called Michael. So again, think about what is problematic here if you could. In many of our institutions, schools, and hospitals, there's a glaring need to create a more gender-affirming environment for not only for learning and research, but for our patient care as well. The tip of the iceberg is language embracing a more gender inclusive and diverse environment. A moment of terminology, if I could. Trans people are individuals whose gender identity or innate sense of gender is different, discontinuous, or more complex than the gender that is culturally assigned to them based on their sex at birth, or the sex assigned to them at birth. The term cisgender man or woman refers to any person who does not currently have a gender identity that is incongruent with their assigned sex at birth. I'd like to just make reference to some commonly used words that at this juncture are considered respectful. This includes trans man, trans woman, trans feminine and trans masculine, masculine of center or feminine of center, and gender non-binary. Language does evolve, and I'll plan to do my best to keep up with the respectful vernacular so that none of my patients, my learners, or my colleagues feel a compromised sense of belonging. This schematic is from a study of trans and gender non-conforming medical students in Canadian training programs. It was designed to understand their experiences. Even though it was small, I believe it elicited rich and enlightening data on this topic. The authors described themes and common experiences that are represented here in this schematic. The trainees described a medical professional culture with persistent underlying cisnormative assumptions about patients, clinicians, and trainees. Much of their negative experiences were related to navigating a cisnormative medical culture. They described a context in which it was almost never acknowledged that trans or gender nonconforming people might be part of their patient population, their classroom, or their clinical team. The cultural context led to recurrent and jarring experiences for participants, many of whom began medical training with the explicit goal of advocating for better care for trans and gender nonconforming patients. The process by which the existence of trans and gender nonconforming people is precluded in healthcare has been termed erasure. So, how can we use inclusive language to support a gender diverse and inclusive environment? Well, I'll offer just a few tips. I'll begin with saying that you don't need to be an expert to be respectful. Always use the name a person asks you to use. Don't make assumptions about pronouns or gender. And of course, role modeling respectful practices with patients, and even hypothetical patients, meaning in your slides at didactics or in your cases that you write, the vignettes that we use for assessments. And if you make a mistake, as humans do as they're trying to form new and better habits, apologize. As Dr. Mason referred to, show that humility and that respect. So back to our case. Michael is a 25-year-old trans man who presented to obstetrics and gynecology for routine health care. I'm going to go on to another case if I could. Sarah is a 21-year-old obese female. She does not exercise other than swimming once per week. She just started about 2 weeks ago. On multiple occasions, she's been counseled about healthy diet, and yet she's not made productive modifications. Therefore, she's not had weight loss or improvement in her symptoms. I'd like to offer a few powerful statistics related to people living with obesity. There are over 650 million people worldwide living with obesity. This prevalence has tripled over the last 40 years, resulting in approximately 4 to 7 million premature deaths per year. A survey of over 5,000 respondents across 4 countries showed pervasive misconceptions about people living with obesity. 79% said that obesity can simply be prevented. 80% said obesity can be treated by following healthy lifestyle. Assumptions with focus on the personal responsibility of a person living with obesity are central to weight stigma. And this brings me back to this schematic, reminding us that when there is perceived element of fault and control, medical conditions tend to be stigmatized. Even if this assumption is not factual or based in pathophysiologic or neuroendocrine knowledge and advancements, as it is in this case. Those living with obesity are also often labeled by this condition as well. The source of internal and external stigma is pervasive in our culture, no less our media. Mocking those living with obesity, making them the butt of jokes, is not simply historic, but continues to be rewarded as a source of entertainment. Potential mechanisms by which weight-related stigma can contribute to obesity includes comorbidities of suffering from prejudice and discrimination, distrust of health services, and low self-esteem due to body image perception, all leading to behavior and physiologic responses perpetuating further weight gain, or at the very least, preventing weight loss. So how can we do better in our language for engaging people living with obesity? Well, first-person language. An individual should not be defined by their condition. Use of language that is free of judgment or negative connotation. Remembering some words are just unacceptable. And I would even ask you to think about the word obese itself. Colloquially, this word obese has negative connotation and can be hugely stigmatizing, even though it's an accepted medical condition that has a definition and so on. Avoid humor, stick to the evidence, and avoid blame and generalization. Stay positive. So instead of describing Sarah in this manner, perhaps we can say, Sarah is a 21-year-old female living with obesity. She has begun to swim once per week. That's very positive. She regularly comes to clinic and engages in counseling about diet modification. Again, something productive. And she has not gained weight since her last visit.
So this is our last case. An 87-year-old demented woman presents to the office. Her son says she has been more aggressive and agitated lately. So by now, I think we're pros at this. Think about what some of the issues are, and we'll come back. So I wanted to include this case because of the enormous stigma associated with dementia and cognitive impairment. More so than many other disorders, patients with dementia are defined by their disease. And we tend to forget about these patients as a whole person. It's one of the most feared diagnoses a person can develop. Dementia is related to the Latin word for mad or insane. In 2013, to try and combat the stigma associated with the word dementia, the DSM-5 replaced the term with major neurocognitive disorder. As a result, most psychiatrists now use this term instead of dementia, at least in formal settings, while neurologists do continue to use the word. The Alzheimer's Society and Alzheimer's associations have developed several guides to try and change the language we use when we talk about dementia. The language has historically been largely negative, focusing on the losses that patients experience. These negative words have contributed to the development and persistence of stereotypes associated with the diagnosis, to approaches that emphasize illness rather than wellness, and the patient is a victim rather than a whole person. In an article in 2014, John Sandblom, one of the co-founders of the Dementia Alliance International, who was diagnosed himself with early onset Alzheimer's at the age of 48, said, "We are just changing in ways the rest of you aren't. We have increasing disabilities, and the sooner it is looked at that way, instead of the stigmas, misunderstandings, and complete lies, the better for all of us living with dementia. We desperately need others to enable us, not further disable us." So let's discuss some language we can use to help decrease the stigma surrounding dementia. We should avoid non-specific words such as aggressive, agitated, challenging, and violent that suggest that the behavior is a result of a problem with the person. Instead, simply describe the behavior. For example, we might say, "The person at night paces up and down the halls and does not go to sleep," or "The person hits when asked to go to the bathroom." Many times, these behaviors indicate that something is bothering the patient, either an external stimulus or an internal one, such as pain. Also, we should avoid words that are typically used for children, such as diapers and adult daycare centers. We can instead say incontinence products or adult briefs and adult day center programs. So let's go back to our case. By now we know that we shouldn't be saying demented patient, but instead say person with dementia. And we should avoid the words aggressive and agitated. So let's try this again. An 87-year-old woman with dementia presents to the office. Her son says she has been appearing more upset, frustrated, and restless recently, and has been striking out when asked to undress. This is specific and non-judgmental. So this slide contains some general principles of how to use inclusive and non-stigmatizing language. Some of these points may have been covered, but I think they're worth repeating, and others are new. First I'd like to say, this is a challenging and humbling topic. I give this talk with humility, with a recognition that language is always evolving, and that we all may say the wrong thing despite our best intentions. We should approach implicit bias, stigma, and language with a humble curiosity, always looking to self-reflect and improve. Remember that language and identity are personal, and that every individual has the right to describe themselves as they wish. And along the same lines, not everyone may want to share their identity, especially in a group setting. We should create a safe space for people to express their identity if they wish to choose so. So in a group, for example, you can introduce yourself with how you would like to be addressed and set the stage for others to do the same if they wish. The next principle we've talked about a few times, but I think it's really crucial. Be thoughtful and intentional about when it's appropriate to refer to a person's race or physical or mental attribute. Do we need to write that a patient is Black in a test question or in the HPI? Or is that more appropriate in the social history? We should use positive language to empower people. And lastly, we as healthcare professionals, and especially medical educators, should be role modeling non-stigmatizing language in patient encounters and in the learning environment. The purpose of this talk is not to simply tell everyone to say this and not that, because there are just too many examples to remember, including many we don't have time to discuss, but instead to recognize the power of words. Here are some take-home points I'd like to leave you with. Words have power, and they can be used both to stigmatize or empower. Implicit bias strongly affects the language we use with patients, colleagues, and learners. Stigmatizing language impacts patient engagement, management, and outcomes. And narratives, stories, and language are deeply interconnected. Opportunities exist at each level of this narrative ecosystem to challenge and dismantle existing injustice and promote health equity.
And finally, I'd like to leave you with this quote from the New York Times writer John McWhorter from September of this past year. Quote, "They tell you mountains become sand, but you never get to see it. language change happens faster, and you actually get to witness it. It's something to treasure. So with that, we thank you for your attention, and we welcome any questions or comments if there's time.
Thank you very much, Elka and Nuri. That was wonderful. A virtual round of applause for them both. Thank you very much. It's fantastic. So if there are some questions actually that are coming through the chat, if you don't mind, I'll help to moderate for you. So we have a question from Ellen Berkowitz. Such an important topic. One issue that may be difficult at times by reframing an HBI is you may be skewing some important background data that may be important in the hypothesis testing or clinical reasoning, leading to the eventual diagnosis, albeit a challenging at times, a bit challenging at times. So do you want to address that specifically?
Sure, I would be happy to. I think, I'm not suggesting that information should be withheld if it, just because you wonder if it's flattering. It's how you present the information. So for example, with the 5th case with the young woman who was living with obesity, it's not that they were factually incorrect, but the terms, but she only started 2 weeks ago. How about she started 2 weeks ago? Ultimately, you're not expecting a major metabolic change based on 2 weeks of exercise, but the idea that she's begun and this is positive change is much more obvious in the second piece, even though the actual information is the same. So I think you're right, and I don't think that information should be withheld. It's how you present it, I think, that leads to the judgment, and being factual and being specific, and also keeping it to the details that relate to your differential diagnosis. For example, the case we presented with the young man with substance use disorder, mentioning that he had to come to clinic because it was court ordered was very biasing, if you will. And it really had nothing to do with the way you would make treatment decisions about him, in my opinion. So I hope that answered the question. And Nuri, I invite you to add or subtract, if you will.
Yeah, I would just add that I think there are going to be times where you do want to include it in the HPI, certain information, but just be thoughtful about it. It doesn't need to happen every time you write a patient note. If you think that, including race or including some other fact is important in that case, and you've thought about it and you've come to that conclusion, I think that's okay.
Great. And Angela Carr says, I think often it's the attitude and tone of presentation that creates the stigma.
I think that's really could sum up our entire talk. So thank you for that comment. That's absolutely right. Does it cast doubt? Does it portray the patient negatively? And if the answer is yes, then rethink the way that you're discussing this person who you're responsible for caring for.
Great. Okay. And Lupa says, how do you reconcile our students' clinical evaluation, which may be threatened by using language that is non-stigmatizing, but not what the evaluator is used to?
I think I need to unpack that. Can you repeat? I'm sorry, I'm looking to read it because how do you reconcile the students' evaluation, which may be threatened?
Okay. So my worry is that our students actually don't come to medical school speaking in stigmatizing ways, and that some of it is the way that they're professionalized, and that they learn how to speak on day 1 of year 3 in ways that is stigmatizing, and it relates to their clinical evaluations.
So this is excellent. We did touch a little bit, and certainly we know that you and your partner today are experts at the hidden curriculum and how we enculturate students. And if the student is trying to stay firm and trying to not go down the pathway of being poorly influenced, and not part of the culture, can that affect their evaluation? And I guess the answer is, unfortunately, perhaps. Perhaps it could. And I think it's our job as the education leadership to make sure that our clerkship directors and unit directors and those who are evaluating the students ultimately and are collecting that information are discriminating in terms of what we include and don't include. And in fact, I'll give a veiled example that we had a student who recognized that a comment on her evaluation use language that is often more likely to be describing a woman than a man. This is evidence-based. She brought it to the attention of her clerkship director, who looked at it and said, "You are right," and eliminated that from her record. So I think part of the purpose of faculty development is to shift culture. And when we're not successful, we need to be the catch, we need to catch those mistakes. And I am very open to other ideas of how to do that better as well. But thank you so much. That's such an important comment.
I think we can take one more comment. This is coming from Susan Law. So grasping these nuances may be challenging, especially in which English is not a primary language. Any tips on that?
Ooh, that's a good question. So I think just taking that approach of humble curiosity and taking that approach of recognizing that people are generally going to be accepting that if a mistake is made and you're using you're having the right intention, that's okay, and asking what is correct. Am I saying the correct thing? I think people are forgiving if the intention is there.
Absolutely, I agree. And I would also say that we just continue to audit yourself. Are you portraying the patient badly? Are you casting doubt? And when nuance isn't easy for you because it's not necessarily ingrained in your formative, experience, it can be a little harder, and humility is the answer, and being willing to say sorry. So thank you, Nuri. That's all we have to say on that. I think we are in agreement.
Great. Thank you both. I think these again, were some very, very helpful hints, and we're all learning. And if we agree that we are all learning and we are works in progress, and we humble ourselves, as you've just said, I think that, we can all do better and to change the culture, particularly for our learners. So thank you again, and a virtual hand clap to you once again.